My name is Joan Anderson, and I serve as a senior rural health project manager at the center. And I have the pleasure of meeting our next two speakers. Both of them are extremely talented audiologists, and they will be presenting addressing the need for hearing evaluation in healthcare. I do a lot of work in the rural public schools and private schools, and I can tell you there are incredible needs. And so their message is going to be very important, the information they share. Dr. Parker Jones is a pediatric audiologist, and she works for the Georgia Mobile Audiology Program. It's housed in the Georgia Department of Health. And she's in numerous professional organizations, has done outreach, has provided leadership. And prior to becoming an audiologist, she worked in the field of deaf and hard of hearing, working in the school systems with children. And she's passionate about language and literacy development with those with deaf or hard of hearing. She lives in South Georgia with her husband and her son. And we also have Dr. Melanie Morris, who is just as accomplished. These are amazing ladies. She is the Chief Health Deputy Director and Referral and Screening Program Director of the Georgia Department of Public Health. She sees and oversees the Office of Child Health, and including a lot of screening, newborn screening, early hearing, detection, intervention, Children's First, and the Behavioral Health and Development Program. Her background is a pediatric audiologist, and she has done a lot of innovative programming with telehealth and outreach. She is very passionate about the underserved populations and promoting early intervention rather than late intervention. She is a believer in the importance of intervention and a very positive driving force behind these efforts. So ladies, come on up. Please welcome them.
Good morning. Thank you so much for that introduction. I am Sarah Jones, and this is Melanie Morris. Like she said, so we're going to be talking about the need for hearing evaluations in healthcare. We're primarily going to be focused on infant newborn screenings and then the follow-up afterwards. But yeah, so just again, I'm Sarah Jones, and this is Melanie Morris. I work for the Department of Education. Melanie works for the Department of Public Health. And we actually used to work together, though, former colleagues, and now we still work together a lot, just in different organizations. But we're both pediatric audiologists by trade. So these are our learning objectives that we'll go over, and we'll kind of address these all throughout the presentation. So we'll start off, and we're going to talk about being able to explain the importance of timely hearing screening and diagnosis for our infants. So one thing I want to point out, and if you work with the Au.D program or anything with hearing screenings, you've probably heard of these before, but I want to talk about what we call our 1-3-6 goals. And so the Joint Commission on Infant Hearing has proposed that in order for children to have proper language and literacy development as they grow, we want to make sure all infants are screened for hearing loss by 1 month of age, and then that they are diagnosed by 3. And so anyone that fails that hearing screening is then diagnosed by 3 months of age, and that any child diagnosed with a permanent hearing loss receives early intervention services by 6 months of age. And so we're going to start by talking about the screening portion of that. So universal newborn hearing screenings. Most states, and I have to emphasize most because there are a few out there that don't have mandated newborn hearing screenings, but most states have a mandated newborn hearing screening. So that means every child is screened for hearing loss at birth prior to leaving the hospital. In Georgia, the children must be screened prior to discharge from the hospital. And then those results are reported in CNE, which is the database that we use. It's a Department of Health database that we use to track hearing screening and diagnostic results up until age 5. Georgia informed consent law doesn't apply to newborn hearing screening, so we don't have to have a written consent from a parent to do the screening in the hospital. It is done. However, the parents can decide to decline. So for religious reasons or other reasons, they can decline the newborn hearing screening, but otherwise it is done on all children prior to discharge. Now, prior to discharge is the goal. Not every child is screened for hearing loss before leaving the hospital. Sometimes equipment is down, there can be misses. It really shouldn't happen, but it can. We also have children that are in the NICU for a long period of time that may not get their hearing screened by 1 month of age, but most children are doing it within that 48 hours after birth before they leave the hospital. So why do we screen for hearing loss? So hearing loss is 2 to 3 out of every 1,000 babies are born with hearing loss. This is some type of hearing loss. It doesn't mean every child, those 2 to 3 are all born profoundly deaf. It means this could be a unilateral. We could have it in one ear. It could be bilateral in both ears, and anywhere on the spectrum from mild to profound hearing loss. In a child with undiagnosed hearing loss, it can impact their communication and language skills. So we think about children learn to speak. They learn to speak by hearing, right? Most of the time. So you hear other adults speaking around you. You hear your parents saying, "Oh, can you pass me the milk?" They hear someone say, "Oh, mom, dad." That's how they learn to speak. So if they're not hearing those things and we don't know they're not hearing them, that speaking is not going to develop. And then our speaking, our way of communication, that develops into our language, our literacy, those patterns as we grow. So if we're not able to address that early and get them the proper interventions they need at a young age, we're kind of setting them back from the beginning. It can also impact their academic and social emotional development as they get older. Also, when we make a diagnosis, so we make a diagnosis, it opens up the door to a lot of services throughout our state that an undiagnosed child wouldn't have access to. We also rescreen. So I was talking about in the hospital, we do a screening before they leave the hospital. So we know some babies are going to fail that screening, right? So typically we do a rescreen before they go straight to a diagnostic test. And that's because we can have up to 10% of babies not passing their first screening. It could be because they have a permanent hearing loss, which we want to check. It could be because they were crying and fussy. So our, by nature, the way we test screen hearing in babies is very sensitive. It's very sensitive to noise. So if a child is moving a lot, is fussy, they're probably going to fail. There could be the vernix in the ear that can cause a failure. And then just test quality issues if the equipment isn't working properly, if the conditions, sometimes I used to screen in hospitals. Sometimes if the air conditioner in the room is too loud, it can cause issues with the test. So it's highly sensitive to noise, and it has to be just by the nature of the test and what they're looking for. So those babies, when they don't pass in the hospital, we do recommend that they have an outpatient rescreen. And when they don't pass 2 of the screens, so they don't pass the one in the hospital and then the outpatient, we then recommend that they have a diagnostic test done via an auditory brainstem response testing. And I will explain that in just a little bit. So this is from the Georgia Language and Literacy Report, and I just want to point out a few things here. In the green, we have Georgia's rate of screening. So the goal is that 95% of babies are screened for hearing loss by 1 month. So that 1 month goal, and you see Georgia, we were 94 the last time this was 2020. So Georgia hovers around that. We do really good with screening. So screenings, and usually we do well with screenings because they're done at the hospital before we leave. So we do them, they get discharged, they go home. You'll see as we go on that we don't do so well with our 3-month goals of diagnostics and our early intervention. But with screening, as a state, Georgia's doing very well. So there are 2 primary ways to do a newborn hearing screening. So we have automated otoacoustic emissions, or OAEs. You may have heard that term before, and an automated auditory brainstem response testing. To point out, these are both automated and they are screenings. They are pass-fail. There's no diagnostic data given at this point when we're doing the screening. The OAE tests the function of the inner ear. So it just goes to the inner ear. It doesn't go past the ear. The auditory brainstem response tests all the way through the brainstem. Either one of these can be done in the hospital. We do recommend the ABR. It is more comprehensive, but some hospitals are still doing OAEs, and that's fine. That's within the law. One thing to point out, any baby that spent more than 5 days in the NICU does need to be screened with an ABR. So at that point, an OAE is no longer an appropriate screening method for that child. And that's because something called auditory neuropathy spectrum disorder that is more common in babies with higher risk factors. Oh, and then Melanie's going to talk a little bit right here.
So I want to take just a brief kind of side tangent and talk a little bit about the birthing facility's responsibilities with reporting the newborn hearing screening. because back to this, the number 3, if we don't get the results of a failed hearing screening to that pediatrician in time, then that pediatrician is not going to be able to make that appropriate referral for a follow-up screening or for diagnostic. So I think it's just important to kind of set the stage. So birthing facilities are required to put the results of the newborn hearing screening in the child's medical record. They're also required to relay it to the primary care physician in writing, typically in the discharge summary. Of note here, it's the PCP that the family has told the hospital of. So that's going to go on that dried blood spot card as well. So as long as that is the accurate provider, that's how it's going to get to that provider. And then they also are required to inform parents verbally and in writing of the hearing screening results. They are also required to provide them with follow-up recommendations. And if the child fails the hearing screening, they're required to give them access to this Have You Heard kind of intensive brochure that kind of talks through the next steps, the importance of follow-up, and then just explaining the importance of timely follow-up testing. So in the last month or so, we've actually at DPH created a form that kind of checks all these boxes for the birthing facility. It gives them access to it gives parents access to a QR code that tells them exactly where they can go for follow-up. It writes out their follow-up recommendations. And so we're trying to make it a little bit easier and a little bit just more like manageable for them to be able to get that information to the next provider. And on this note, figure if we have some pediatricians in the room, it might be helpful to cover how to access the newborn screening results in general. So we have our hearing screening results, which you get those results the second that you're done with the test. That's like pretty easy to give the parent the results and the pediatrician the results. But for the metabolic screening, you send that blood sample off. You're not going to have those results until about a week later. So we have a couple different ways of accessing these results: hearing, cardiac, and metabolic. So one, for the dried blood spot or the metabolic screening, those results are mailed to the submitter. So that would be the birthing facility who collected it, and whoever they wrote down as that primary care physician, that's who will get a report of those metabolic results. If, for instance, the family told the hospital their pediatrician's this practice and they went to another practice, that other practice is not going to have that result from the lab. And so pediatricians can access those metabolic screenings through a database called eReports. And you do have to be a licensed physician. They don't let MPs or physician assistants have access to it, so you have to be a physician in order to access it. And when I started at DPH about a year ago, the first thing I did is I log in and I see that I have to type in a kit number, like the lab, like form ID number. If any of y'all have seen this, you have to have this very specific number. And so luckily we have been working with legal and we've expanded that. So in the coming months, you should be able to search for the metabolic screening by mother's last name. You have to type in like mother's last name, date of birth, and birthing facility. So you have more options for pulling those results. And then, of course, we have our SENS system, which we're going to be talking about a few different times throughout this presentation. SENS is primarily used for all of our hearing follow-up. And then last, if you can't get it via any of these other methods, you can email this email at the bottom. My team runs it, so we will get back to you and we will give you those results as soon as possible. Our goal is that you don't have to manually email somebody and ask for results, but if you have to, we've got you.
All right. So now we're going to move on to the 3 in our, in our goals. So remember, we have screening is the goal is to have that done by 1 month, and then diagnosis. We want to have anyone that failed their newborn hearing screening to be diagnosed or have a diagnostic evaluation by 3 months of age. And so bad news. Georgia doesn't do, so we did really well. We are at 94%, hovering 94, 95 with screening. When we go to having a diagnostic evaluation done by 3 months of age, we're at about 22%. So we have a huge drop. So we're getting screened, right? These children are getting screened in the hospital before they leave by that 1 month, and we're doing that really well. But we have this huge drop when we go to getting a diagnostic evaluation on time. One caveat is that doesn't mean only 22% are getting diagnostic. They may just be getting them later, which is better than not getting them at all, but it's still, we want to make sure we're doing it in a timely manner. So this could be they're getting them at 4 months, 5 months, 6 months, but we do want to make sure they're getting them in a timely manner. So we have a lot of room for improvement in that area. So why are we so low, right? So we see this huge drop, but kind of why and how do we address it? So there's a lot of different reasons. The system in general can be confusing for parents to navigate, especially if you're in a rural area that doesn't have as many resources. So if you don't live in Metro Atlanta and you can't just take your kid to CHOA, what do you do? So the family's got to find an audiologist, and they have to find an audiologist that does ABRs. This is a pretty specific test. It's pretty specialized. Not that many audiologists do them. And the reimbursement is usually low for the time and that it takes and the equipment cost. So that's why a lot of audiologists choose not to do them in private practice, because they're not going to get reimbursed for their time. Facilities, and then because there aren't as many that doing them, we have long wait lists, right? So I say you could just go to CHOA, but CHOA has a long wait list for ABRs because there's not as many people that do them. And then health insurance can be an obstacle as well. So prior authorization, you often have to have, and there aren't a lot of places that just do these for free, right? We'll talk a little bit about one option that does in a little bit here, but there aren't that many. Also because we have to report, right? So if we have a reporting problem, like Melanie said, if the screenings aren't being put into our CIN system, then our Au.D coordinators don't know to contact the families to tell them they need a second screening, right? So we have to make sure they're getting reported into CINs in a timely manner in order for us to know to trigger a follow-up for that diagnostic test. We also have the lack of documentation from birthing facilities in some areas. So this kind of goes to that lack of reporting. But if the birthing facility isn't reporting their screening results at all or in a timely manner, then how do we know? And then we also have potential for misinformation. We do have sometimes where children's doctors are saying, oh, it's just fluid. You probably don't need to follow up. Don't worry about that. Or screeners in the hospitals will sometimes say that to kind of make parents feel a little bit better, to placate them. Well, it's probably just fluid. That's probably why they failed. And sometimes it is. However, we really caution against saying it may be just fluid, because parents really like to latch on to the best news possible, right? They're going to think, oh, it's probably just fluid. Then I probably don't really need to follow up. I don't need to take them for a future hearing test. And then we also have an issue with training at hospitals where we're not having the most quality screenings happen sometimes. And the trainings haven't, and so we have too many babies referring. So like I said before, we have that 2 to 3 out of every 1,000 babies are born with hearing loss statistically. But sometimes we have hospitals referring 20% of their babies. Something doesn't add up, right? So we need to make sure hospitals are well trained and that their equipment's working, so their refer rate is lower. So then the babies that are actually receiving diagnostic testing are the ones that really need it. So Georgia Mobile Audiology under the Department of Education is who I work with. And so we are trying to address this diagnostic problem, and we partner a lot with the Department of Health in order to do this. And so we offer free diagnostic clinics for children and infants throughout the state. And so we do infant testing, and then we also do older testing for school-age students. And we aren't touching on that as much today, but I will talk to you a little bit at the end. We provide full diagnostic testing, and most of these are done through teleclinics. So, and they're rural parts of the area. So we're in Lowndes County, we're in Tift County, we're in Albany. We're all throughout. So we really focus on, we're in a lot of places, and we're expanding as well. So we provide these teleservices. They're typically done at the health department in coordination with Au.D coordinators. And we have kind of a test assistant in person, and the audiologist is usually virtual from their home conducting the testing. We have a sister program that provides parent navigation services. They help families get to appointments. They provide directions beforehand, which really decreases our loss to follow-up. And they also provide families with guidance and care after appointments. So they provide information on language nutrition to all families. And then families that were diagnosed with hearing loss, they really walk them through the process, help them get connected with ENTs, help them with transportation and just general support. So I'm going to talk really briefly about how a diagnostic appointment would go. So we do a battery of tests, starting with one that we do often is called tympanometry. And this allows us to check to see if there's fluid behind the eardrum. Basically put in positive and negative pressure into the ear canal, and the eardrum either moves or it doesn't. And if it moves, we have a normal result, this nice peak, and we know that there's not fluid behind the eardrum. If it doesn't, we have this flat line right there where we know that, hey, there's either fluid behind the eardrum, or there's maybe still vernix in the ear, or wax or something like that that's not allowing the eardrum to move like it should. The next test that we often do is called otoacoustic admissions. And this is when we play very low level sounds into the ear. And then our ear actually can send us a signal back that we're able to record. So if we have a healthy ear and a healthy cochlea, we have hair cells that move in response to sound, and they're able to send us a response back that we can record. This test is highly sensitive to fluid in the middle ear. So if there's fluid in the middle ear, like we got on the test prior, likely the child will not pass this test. And that's just something to know. Like I said, it tests the inner ear, the cochlea, but it stops at the ear. It does not test farther than the ear. It does not test up through the brainstem or through our auditory nerve, and it cannot be used to diagnose hearing loss or to give us hearing thresholds. It gives us information about auditory function, but it is not a true test of hearing, and it cannot be used to diagnose. So that's important to know. Next, we have our auditory brainstem response testing, or ABR, and this is really our gold standard for testing hearing and diagnosing hearing in infants. This is electrophysiological response of the auditory system. So we basically are able to place sounds into the ear, soft sounds, and the child will have electrodes on their forehead and behind their ears, and we're able to record the brain's response to sound. So it goes all the way through it tests it through the brainstem, and the result is usually it's displayed in a waveform. So we're really looking for this wave 5 here, but if everything's really nice and pretty, you might get all your waves, but wave 5 is the one that's the most important. The child does have to be asleep during this test, so that's again why the younger the better. We know that a 1-month-old sleeps a lot better than a 7-month-old, right? Is a lot more cooperative when we're putting things on their head. It can take up to 2 hours as well. It really depends on cooperation, what we're finding, and it has to be done by a licensed audiologist. So this test needs to be performed by a licensed audiologist. This is just another example. We won't go through all of it, but it just shows here that the OAEs only test to the level of the ear and the cochlea, and then we see that the ABR tests all the way through the brainstem, and each hump or each peak in our waveform is actually connected to a different generator in the brainstem. So now we're going to talk about language and literacy, the relationship between early diagnosis and intervention and language and literacy outcomes. So we're here again with our 1-3-6. 1 is screening by 1 month of age, 3 is diagnosis by 3 months, and then 6 is enrollment in early intervention by 6 months of age. And so that's children who are diagnosed with hearing loss being enrolled in intervention by 6 months. So bad news again. If our diagnosis isn't good, our enrollment in early intervention is likely also not going to be good, right? So we're here at enrollment in early intervention by 6 months of age is at about 23%. So that means of the children that were diagnosed with a permanent hearing loss, only about 23% of them are being enrolled in earlier intervention by 6 months of age. Another thing we want to point out is this has a direct correlation with language and literacy outcomes and reading outcomes as we get older. So we also have, an issue where children who are deaf and hard of hearing aren't reading on grade level. But let's think about it. If they're not diagnosed on time, they're not receiving intervention on time, they're not going to read on grade level, right, by 3rd grade. So this is why this is so important. So in 2019, only about 15% of children who had a primary eligibility of DHH in the school system were reading on grade level on the 3rd grade assessment. I do know assessments aren't everything. Standardized tests aren't everything, but they are an important way for us to monitor progress. So this is a study by Christina Yoshinaga-Atano. It's an older study. It's from the late 90s, so I do know that's older, but it's it's like an oldie but a goodie. And it shows the correlation between language, age of identification intervention, and language and literacy outcomes. So just to orient you guys, on the x-axis we have age of identification in months, and on the y we have language outcome scores. So this first one right here, 0 to 6 months, and then the blue area is the typical development for same age peers that did not have a hearing loss. And the only group of children with hearing loss that fell into that same category and achieved the same scores as their same age peers was those that were diagnosed from 0 to 6 months of age. So every other group fell beyond that category, beyond that quotient of their same age peers. So that's in that typical development. This study is really interesting because it cross boundaries of socioeconomic status, of modality, so whether they're using sign language or spoken language. The only thing that really mattered in this study was age of identification, and it showed that this age of identification was so important that these children were achieving on the same level as their hearing peers. This is a similar study, except for it has two groups of children with hearing loss. These children were identified early, and these were identified later. These children were identified by 6 months, and these were identified later. And it shows here in every category as well: visual vocabulary, grammar, word production. They all achieved higher levels than their late identified peers. So again, just kind of highlighting that we do have, it's not just 1 through 6 for fun. It really has real meaningful impacts on our children. And so now we're going to talk about some services in this state and how we get children where they need to go. So I'll let Melanie take this one again.
So this is probably the most boring part of services in the state, but data is so important. So we've talked about it before earlier in the presentation on how we need that first data point of a failed screening in order to then set this child up for success. And if we don't have that failed screening or that diagnosis of hearing loss entered into our data system, CENS, then we don't know that they exist and we can't get them connected to resources. So CENS does serve a really big purpose. It stores and analyzes all of our data of 1 through 6. We can actually pull data on every district and figure out how are you doing in each of those different benchmarks. And that can kind of help guide what interventions we need to put in place. And then I'll actually skip to this next slide. So when an audiologist, they are required to enter when there is a diagnosis of hearing loss into CENS within 7 days. So hearing loss in Georgia is on our notifiable disease list. And so they are required by law to enter a permanent hearing loss into CENS. And for good reason. Once that is entered, we automatically send these referrals to early intervention supports. So the district Au.D coordinator, they get that diagnosis and then they help coordinate enrollment into our other child health programs. So Babies Can't Wait, they automatically, any child with a permanent hearing loss automatically qualifies for Babies Can't Wait, and then potentially could qualify for CMS depending on income qualifications. The state, so Brant Culpepper, who's the state Au.D program manager, she actually requests a Georgia testing identification number. I won't go into a ton of detail on this, but this is in partnership with the Department of Education. And the goal is that every child who is diagnosed as being deaf or hard of hearing, they get a specific GTID number. And so that way we can truly, and this just started about 5 years ago, when they get to 3rd grade, we can accurately look at how is language, how is literacy, are they reading on grade level? For the group that is reading on grade level, what was their story like? So we can really try and tease out these patterns and try and impact greater change. These children, once a diagnosis has been made, they automatically get a referral to Georgia Pines, which is kind of a sister program at Department of Ed. And they offer like family support and family education for children that have sensory loss, so vision and or hearing. And then they also get a referral to Georgia Hands and Voices, which basically links the family with a parent who has also walked this journey. So that's why CENS is so important. When I was an audiologist at SHOA, I would enter it because I just was told I had to enter it, but I never really knew why. And so some of these they can fall through the cracks. You're busy, you're running these really busy practices. But now I think it's just really important to see what all happens once that diagnosis is made and entered. Yeah, we can skip that.
Yeah. So we talked a little bit earlier about a lack of access, right? So sometimes we can't do these diagnostic tests because we don't have the access for them. This map can be maybe a little bit confusing, but it shows in 2019, the places that were blue, light blue or dark blue on the map is where we had pediatric diagnostic centers in 2019. Georgia Mobile Audiology, in partnership with the Department of Health, really took an initiative to try to expand those services throughout the state. So just to orient you, anywhere that is red on the state is where we have a teleaudiology site. Anywhere that is green on the state is where we have a mobile site. And then anywhere that is yellow is a tele and mobile site. And we're not talking a whole lot about our mobile stuff right now, but one thing I will plug is we do have a mobile unit. So we have a mobile sound booth that we can actually move from place to place. And we actually have it here today. So we'd love for you guys to go out and check it out when we have some break time and vendor time. It's in the courtyard area, but it's really neat. And we use it to test school age children. So you can see that the largest area, so the darker the blue is where we have is the more services. And this is that metro Atlanta area. So most of those services are there. So GMA really tried to concentrate on expanding services to rural areas and places that didn't have services already. We know there's still a lot of work to be done. We know we've got some open area here. We are slowly but surely expanding and opening more clinics and more teleclinics that we're trying to reach out to more people. We do have a find an audiologist map on our website, and I actually have a QR code for that you'll see later. And then there's also our website at the end that allows you to see who the audiologists are throughout the state. So teleclinics, I'm actually going to point out, that's Melanie. She's both the patient and the audiologist in this one. But so this is Melanie with her son, Oliver. But so our teleclinics, just to give you an idea of how they work. So we have the patient in their in the health department typically. And then they are usually there with our parent navigators kind of play back. They act as our test assistants, and that person will set them up, and the audiologist is there via Zoom. Now, it's important to know that the audiologist runs the test completely. So the parent navigator that's there in person just acts as the hands of the audiologist. They put the electrodes on the skin. They do everything with direction from the audiologist, but the audiologist runs the entire test. So we're able to run a complete ABR via tele through Zoom. Zoom can be a HIPAA compliant platform as long as you make sure you go through those the steps to do so. So we use a HIPAA compliant Zoom platform. And so here you again see the patient in the health department, and there's the parent navigator, and then the audiologist at their home that's able to run the test. And the reason we kind of did it like this is audiologists, there are so few audiologists, pediatric audiologists in our state, but we were able to hire these parent navigators that live in these local regions that can act as kind of the hands of the audiologist, and the audiologist can be in Atlanta or wherever they live and provide this testing. And then as the test is done, we are able to summarize everything for the family, give them a diagnosis of normal hearing or hearing loss, the type and the degree of hearing loss, and go over all of that with the family in this appointment. So that can all happen via tele. So, and this just is these are some graphs about kind of the expansion of telehealth in the state of Georgia. So in 2020? Yeah, in 2020, we had about 15 tele appointments happening in the state, and those were all done by Children's Healthcare of Atlanta. And then in 2021, you see where we expanded, and then 2022, we've kind of really taken off. And the dark blue is GMA, Georgia Mobile Audiology. So we've really expanded and taken off, and we're able to provide more telehealth opportunities throughout the state. Children's Healthcare of Atlanta is also providing some telehealth for audiology as well, in partnership with the Lowndes Valdosta Health Department. And this is a map or a graph of where we are providing the most services. So you see Valdosta here has the most telehealth patients are coming through the Valdosta area. And we have a clinic in Valdosta, and so does CHOA. And then Waycross is a big chunk, Albany. So if you see really here, these are all in the South Georgia area. Technically, Valdosta is not considered rural, but that Lowndes Valdosta DPH covers a lot of rural counties, Berrien, Turner, some other ones in that area that are rural counties. But you see that, so most of these are really happening in rural areas of the state.
And we actually have,
oh yeah, I wasn't going to do it too.
I know, I'm going to make it. We have one of our EDIs, our early hearing detection and intervention coordinators, who is the assistant for CHOA. She's here. So Valdosta, she's from Valdosta. Katina has been kind of there she is, boots on the ground. Wave your hand, Katina. And we weren't going to look at by district, but Valdosta has one of the lowest loss to follow-up data sets in the whole state. And I think there are many reasons for that. I think one of the many, is probably because there is access to diagnostic. But just wanted to make sure we got that shout out.
And yeah, I wasn't going to do it to you, Katina, but she does a wonderful job, and we're so lucky to have her there. And yeah, she gets them in. We meet 136 in that district for sure. So let's see. And so this is the QR code I was telling you about for Find Your Audiologist on our website. It's also on our website, on the GMA website. But this is kind of an example of what it looks like. So we have We have tried to take surveys from all the audiologists throughout the state. If you look at this and we're missing somebody, tell us. We're happy to add them. We are kind of revamping this as well right now and we're trying to add all services for children who are deaf and hard of hearing. So earlier interventionists, speech, language, trying to create like an even bigger database. But this is what we have right now. And as you click on each one, it'll kind of tell you what they do. So it'll tell you if they provide diagnostic ABRs for infants or they don't start seeing children until they're 2. It shows you what insurances they take, if they take Medicaid or not, all those things. So it's a really cool map. And Dr. Morris, when she worked for us, she's the one that created this. So really shout out to her. And the last thing we're going to talk about a little bit, it kind of doesn't fit into any of our learning objectives, but it's important. It's going to lead into the next part of our presentation, are the Joint Commission of Infant Hearing, their risk factors that they say for hearing loss. So we know that 2 to 3 out of every 1,000 are born with hearing loss, but children can also develop late onset or progressive hearing loss as they get older. And these are often associated with what we call risk factors for hearing loss. So when these can be family history, it could be a syndrome associated with hearing loss. Like my son has Down syndrome, so he will need to be monitored for hearing loss as he gets older because that's a syndrome that's associated with hearing loss. Ototoxic medications, gentamicin, tobramycin, if they're given those by IV in the hospital, that's a risk factor. And one big one is called congenital cytomegalovirus, or CMV. You may have heard about it. There's kind of hot on the press right now, and Dr. Morris is going to talk to you a little bit about that in a second. But the important thing to know about this is if you ever have patients with any of these risk factors, they do need to be monitored for hearing loss as they get older. So we do have that screening at birth, and they passed it. That's great, but we still recommend monitoring as they grow. And so, or even if they have the diagnosis, if they failed in the hospital and had a diagnosis, we recommend monitoring. It's usually, depending on the association, it's usually up until age 3 or age 5 when the monitoring tapers off. But yeah, so I will hand it over to you.
Okay, so thanks for bearing with us. I know you've been sitting for a while. We have probably about 15 more minutes of content, and then we'll save some time for some questions. So I'm going to be talking about congenital cytomegalovirus. That's what I was asked to do here, because there is a lot of effort kind of going on in Georgia and nationwide around congenital cytomegalovirus. Raise your hand if you've heard of CCMV. Awesome. Okay. Raise your hand if you have a patient or have ever treated a patient that had a diagnosis of CCMV. Much fewer hands, but still, yeah. So I'm going to go over, some of this will probably be repeat for those of you who have had patients with CCMV, but I'm also going to give some updates on what's happening in Georgia. There's a lot happening in Georgia, so I'm here to kind of spread the word. So congenital CMV is much different than CMV. So first we're going to start with, where's the pointer?
It's the great thing at the top.
Okay. Yeah. First, we're going to start with just plain old CMV. It's a very common virus, just kind of like the common cold. Most of us have probably had it, especially because we work in the medical field. It's part of the herpes family. So once you're infected, it can stay in your body in an inactive state and reactivate at any point. It's very, very common in children ages 1 to 3, particularly because it's spread by direct and indirect close contact with bodily fluids. So kids are snotty. They don't know rules. They slobber over everything. So that's where kind of that population is most impacted. And then in the United States, 1 in 3 children have been infected by the age of 5, and 50% of adults have been infected by 40 years of age. So it's, when you're not pregnant, not really a big deal. However, when you are pregnant, it's a really big deal. So congenital cytomegalovirus is when CMV is acquired by the fetus in utero. Infants can be asymptomatic or symptomatic. I think the asymptomatic is a little bit of a misnomer because there are kind of some silent symptoms that maybe you don't really pick up on at first. So I think there are probably more data is going to come out that's going to show us there probably is slightly higher symptomatic cases. And it's the most common infectious disease cause of birth defects in the United States. So it impacts approximately 1 in every 200 births. And it is the leading cause of non-genetic childhood onset sensorineural hearing loss, which is why we're kind of combining these presentations today. So let's talk about CCMV and hearing loss. 10 to 15% of asymptomatic CCMV positive cases or positive infants will have hearing loss at birth or experience an onset or progressive hearing loss. I want to make note that right now, They are considering asymptomatic if there's no other symptoms, like no brain calcifications, nothing else, only hearing loss. Even though hearing loss is a symptom, it's considered asymptomatic. So that's important as we kind of talk through some additional details. And then in the United States, 15 to 20% of all cases of bilateral, moderate to profound sensorineural hearing loss are due to CCMV. So audiologists have known about CCMV for a long time because a lot of our population that's probably part of the reason why or might be the reason why they have hearing loss. So symptomatic children, so children that have more than just the hearing loss or have anything, so they're more likely to have hearing loss compared to their asymptomatic peers. And 22, it's a wide range, 22 to 65% of symptomatic cases have hearing loss. 6 to 23 of asymptomatic cases will have hearing loss. The hearing loss can look like a lot of different configurations. It can start off as one ear. It can be bilateral. It can be mild. It can be profound. However, what we found is that if it does start off as unilateral, that poorer hearing ear is more likely to progress. And then majority of patients that have a unilateral hearing loss when they're born will end up developing hearing loss in the other ear. And so this is really significant for audiologists as we figure out management of these cases. Managing an infant with just a mild unilateral hearing loss versus a bilateral hearing loss, they're just very different management kind of considerations. And then progressive and late onset hearing loss is very common. So this is from the National CMV Foundation. They are an incredible organization, and they give all sorts of freebies and free graphics, free educational resources. I actually have some on the DPH table if you want to take any to your practice. But approximately 1 out of 3 pregnant women who become infected with CMV will pass the virus on to their unborn child. So this means that 2 out of 3 might get CMV and then they wouldn't pass it, but that's still a large chunk of individuals who could pass this on. It's approximated that 1 child is permanently disabled by congenital CMV every hour, and then 1 in 2 children are born with congenital CMV every year. I won't read these, but we have 3 position statements that have come out in the last couple of years. The American Academy of Audiology, as well as the Joint Committee on Infant Hearing, their position statement. So really highlighting to do a full workup when a child is diagnosed with hearing loss to include CCMV testing if the age is appropriate. And then the American Academy of Otolaryngology had a neck and surgery position statement in February. They actually came out and recommended universal newborn CCMV screening. Sorry about the formatting, not sure what happened there, but that's Florida, that's kind of covered up. So just so y'all are aware of what's happening nationally, states with hearing targeted, so hearing targeted screening. So that means they're only going to screen the babies that failed that hearing screening at the hospital. Every time I make this slide, I add a new state. It's coming out like every single month. New states are adding this. I anticipate seeing Georgia on this in the next few months. So we're going to talk about that. And then the states that have universal CCMV screening are a bit fewer. So Minnesota, Connecticut, and then New York is doing it for a grant. But we're going to talk a little bit about, for the states that are doing hearing targeted, they are screening with urine or saliva. The states that are doing universal, these are using blood spot. So they're using that because that's part of the pathway of the newborn screening process. You take that blood spot and you just test it for a new condition. You test it for CCMV. But we're going to talk a little bit about the different screening methods and kind of like the pros and cons of each. So universal, that would be testing all infants for CCMV. Universal is like our hearing screening. So we test every single baby that is born in Georgia with for hearing loss. Whereas hearing targeted would be testing for CCMV after a baby has failed 1 or 2 screenings. It kind of depends. Most states that we saw on this list are recommending that they have that test done before the child leaves the hospital. And the reason why is because of this. This is like the most important, if you remember nothing else, this is the most important. They have to be screened before 21 days of age, which makes it really challenging. And if you're going to do a hearing targeted CCMV screening program, you have to do it before they leave the hospital, because otherwise there's no way we're going to get that baby back, screen them, and get that result in time. And so in Georgia, actually, I'll tell a little bit of history. So about 6 years ago, Georgia Academy of Pediatrics actually came to Georgia Department of Public Health's Newborn Screening Genetics and Advisory Committee group, and basically asked them if they would consider adding CCMV to the universal dried blood spot panel. And so there has been so much work being done in the last 6 years. They've had these working groups. They've looked at updated research to figure out, is this something that they would recommend? Ultimately, they said no to universal dried blood spot for a couple reasons. One, the dried blood spot has a much lower viral load. And it's also a little bit less available unless you're doing it as part of the dried blood spot card. But the challenge is that for the blood, since there is a lower viral load, if you get a negative, you don't know for sure that it was negative. And so that was one of the reasons why they said no. The other main reason is because of treatment, and we're going to talk about that at a later point. But for most of the states, and what Georgia is considering is a hearing-targeted CCMV screening program. And so these are the two test methods that they would be doing. So saliva or urine PCR, LabCorp, Quest, all the normal labs can do this testing. The challenge with these two is that it's not part of an existing newborn screening program. It's not universal. So in some ways, universal is a little bit easier because it's just automatic. You just test everybody. It goes through the Georgia Public Health Laboratory. But that's not really the case when you're using a different type of specimen other than blood. A potential challenge with saliva is there could be contamination with breast milk. So the mother may have CMV antibodies, but that doesn't mean that she has an active CMV infection or that the fetus does. So we have protocols on waiting at least an hour up to 2 hours between breastfeeding and doing the swab. Urine is the confirmatory test. Saliva is the first tier screening. So typically what most states are doing is at the hospital, they'll do a saliva PCR. If it's negative, we've ruled it out. That child is done. They don't have any more testing. If it is positive, then they have to have a confirmatory urine analysis. So they have to have the urine PCR. I was wondering, I'm why can't we just go straight to urine? And then some really smart people informed me that newborns don't urinate much in that first 24 hours. So otherwise you're waiting for them to leave. You're not discharging them in time. So it just doesn't really make sense. But if you see a child in your practice that's nearing that 21 days mark, and they've failed a hearing screening, or they've been diagnosed with hearing loss and they haven't had a saliva screening, I would go straight to urine, because otherwise you're going to run out of time. So we're going to talk a little bit very briefly, because hearing is kind of my main area of expertise, and a lot of this is not. But there are many other signs and symptoms of CCMV besides hearing loss. And it's definitely too hard I can't see it on my own screen. But some of the most, this is what I did. I wrote them out because I knew that was going to be hard. The most common signs of CCMV: hearing loss, microcephaly, little red spots on your skin, vision issues, so chorioretinitis, intrauterine growth restriction, cerebral palsy. So a lot of different NICU babies that maybe you don't really know why, they don't have a firm diagnosis, but they ended up in the NICU. They could be at risk of CCMV if they have some of these signs and symptoms. So briefly, we'll talk about treatment. When I came to DPH, and I'm the liaison between DPH and the Newborn Screening Genetics and Advisory Committee, where they're looking at all these conditions, GAMT or MPS 2 and all these things, trying to figure out, is this a condition that we are going to add to our universal screening panel? One of the main criteria is there treatment available? So if we're going to screen for something, is there treatment to do something, intervene? For CCMV, it's a little bit tricky. The jury's still out. So typically, If the child is symptomatic, so more than just hearing loss, typically they will offer antiviral treatment to that family. It's from my understanding, with talking to some infectious disease physicians at Showa, that if that child just has hearing loss and they're CCMV positive, and the infectious disease practice, their physicians will have shared decision making with that family as to whether or not they want to try antivirals. But overall, like, the FDA has not approved antivirals for asymptomatic cases of CCMV because of the risk of neutropenia. And then there's also this question of, when they stop the treatment, is the hearing loss going to come back? Because that viral replication is rebounding. But there is an ongoing study that's looking at whether or not it improves hearing thresholds and language scores. So hopefully we'll get that soon. But what I have kind of hit home with is, like, treatment doesn't always have to be a medical, like a drug. It doesn't have to be a drug. It is so incredibly important to know if a child has CCMV for all of their other risk factors. Their risk factors of progressive hearing loss, their risk factors of vision issues, developmental disorders. And so by having this information, we can manage them a lot more, just differently. So for a child that has CCMV, you definitely want to have frequent and routine hearing tests. So you would want to connect them with an audiologist who's going to monitor their hearing frequently. We're going to look at amplification if spoken language is what the family wants. And it's going to change what I decide as far as what hearing aid I'm going to fit for that child. If I see a baby that comes in and they have just a unilateral mild loss, I'm expecting that they're going to end up having a bilateral loss that's progressive. So I might choose a slightly bigger hearing aid that I can give them more volume. It can change cochlear implant candidacies as well. So it can kind of move that timeline forward and get that child implanted much sooner if we know that they have a diagnosis of CCMV, because we're expecting their hearing to progress. And then vision surveillance and developmental surveillance. I'm going to speed through this. Okay, we're going to jump right here. All right, so patients suspected of having congenital CMV, are they under 21 days of age? Yes. We're going to do a urine or saliva PCR. If it's negative, they're done. They don't have CCMV. If it's a positive saliva, you're going to confirm it with urine. If that's positive, then you've now confirmed a diagnosis of CCMV. Then these are the standard referrals that they're recommending. So typically a referral for ophthalmology, infectious disease is a big one, audiology. So an audiologist can do the diagnostic ABR. Just like Sarah mentioned, there are not a ton that do that test, but they cannot have a rescreen. They have to have a diagnostic ABR. Potentially more blood work, as well as cranial imaging. I'm going to kind of skip through some of this because we're running out of time. If they are symptomatic, this is where the infectious disease, I don't need to know this. The infectious disease, they've got it. They will have these discussions about considering antiviral medications. So overall, as monitoring for these kids that have CCMV, these are kind of your main areas. So vision, hearing, general developmental surveillance. So that might include speech, occupational, physical therapy. And a quick note, as of 2 weeks ago, Babies Can't Wait has now added congenital cytomegalovirus to their Category 1 list. What that means is any child who has a diagnosis of CCMV automatically qualifies for Babies Can't Wait. They do not have to have a diagnosed hearing loss, because that also qualifies them. But because of all the risks of potential hearing progression, as well as just general balance issues, just motor issues, just kind of the whole area, they now qualify, which is great. Okay, this is for medical home. So prevention is pretty limited. It's not necessarily prevention. Like, I think about education to, a potentially expectant mother who might have a toddler in daycare. It's all about reducing the risk, not eliminating the risk. So working with them on, don't share the straw with your toddler. Don't share food with your toddler. Don't pick up their pacifier off the floor and put it in your mouth to clean it up. And so just kind of reducing those risks, but also just being aware of which populations are at the highest risk. So child care workers, 10 to 20% of individuals that had that passed on CCMV were child care workers. Parents with another child in daycare is the biggest one. And then our minority population, so non-Hispanic, Black, and Mexican Americans are disproportionately impacted with this. And once again, not sure what happened with my formatting. So this is the last slide. All right, so confirmed, if you have a patient that has confirmed CCMV diagnosis, you're going to want to make those referrals to infectious disease, ophthalmology, audiology, making that referral to Children First, which is going to enroll them in Babies Can't Wait, and just monitoring their development a little bit more closely than you would a typical child without the diagnosis. Now, this is going to be what's more common. You have no confirmed CCMV diagnosis yet, but let's say that child's under the age of 21 days. If they have any of those symptoms that I mentioned, so cerebral palsy, in uterine growth restriction, those sorts of things, and you were suspecting it could be CCMV and they're under 21 days of age, I would go ahead and order and document that CCMV testing. And then educating parents on the importance of this timely, quick follow-up. I know I'm running out of time. Let me just give the quick, 1 minute spiel of Georgia. So, the Newborn Screening Genetics Advisory Committee ultimately said no to universal screening, but they had a subcommittee that got back together last year. And in September of 2023, the subcommittee of audiologists, ear, nose, and throat doctors, neonatologists, infectious disease, they ultimately recommended that DPH consider editing our rules and regulations around hearing screening to incorporate the requirement for birthing facilities to do hearing targeted CCMV screening. So we have been doing a lot of work behind the scenes, meeting with stakeholders, hospital organizations, Wellstar, CHOA, all the hospitals to kind of get a pulse check on how they feel about it. We have gotten incredible feedback. People are interested and eager for this. And so I just submitted the rules and regulations edit to our government affairs office last month. They're pulling everything together, and the process for that is they'll have a public comment period for 30 days. If there's no major edits, it'll go into effect about 30 days after that. So we are looking at a potential rollout of this 2 months once they post it for public comment. So I am guesstimating August. And we're going to have we have a stakeholder group of 25 individuals from across the state. They're building out our policy and procedure manual to kind of walk birthing facilities and primary care physicians through every step. And so if you want me to email you and get on this list of you want these updates of when CCMV is rolling out, where to find the resources, just scan this and type in your name and your email address, and I'm kind of compiling all this and we'll make sure to update you. Okay.
Good job.
Any questions? We have 30 seconds. We're both going to be at our tables. She'll be at the Division of State Schools table, and I'll be at Department of Public Health. Yes, Monica.
Go back to the QR.
Oh, yes, thank you. Yes.
In a baby born in Wayne County, go to Ware County to have their diagnostic ABR done.
Yes. Mm-hmm. Absolutely.
Absolutely. Yeah. So Wayne County, Jessup, right? Yeah. So I would be the audiologist that'd be doing the testing. So they absolutely can. If you go to our website and if you want to just come meet me at our table later, I can give you the information and we can talk to you about how you would do that scheduling. And LaToya Hamilton is the EDDI coordinator that is out of Waycross. I don't know if Wayne is in that same district or not. They're right next to each other, but I'm not sure if they're in the same district or not.
I've done it.
The same district.
Yeah, are they? Oh,
Okay.
then yeah, perfect.
Oh,
yeah, absolutely.
I've been to the Jessup Public Library and did an ABR there.
Yep. Mhm.
On an infant. Yep, at the library. We get very scrappy.
Yeah, we're not at the library anymore. We're at the South Georgia Regional Commission building in Waycross.
Yeah.
But,
Okay.
any other questions?
Let's see us getting booted.
All right. Thank you.
Thank you.